I'll mention three today. The first is political commitment and will. The second is fiscal space. And the third is smart governance. So political commitment and will is more than rhetorically supporting UHC. That's of course important. But it also means building support within the institutions of the state and the institutions of society. So that could include civil society, medical associations, and others. And it also means actively building out fiscal space. And fiscal space is the second point. Fiscal space means essentially more money for UHC. How do you generate more resources for UHC? There are three ways you can do this. One, the nicest way, and the way that's often discussed, is the government simply allocates more money for health. But we know that the governments are under pressure to allocate money for many social sectors, so this may not always be realistic. The other two ways that perhaps aren't talked about as much is one is efficiency gains. So within the health system, you can actually garner significant efficiency gains, and we'll discuss that a little bit in the following question. And the third is the old mantra of growth. If you have economic growth, and that results in increased government tax revenues, this will probably lead to, if revenues are allocated equitably, more money for health. And finally, smart governance. And really what that means is the ability to manage a health system, a complex health system, in an intelligent manner. So that means most fundamentally building out not only the capacity of individuals within a ministry, but all of the parastatal and academic institutes that are responsible for doing analysis and measurement of system processes. I think there's been actually many challenges, but I'll just focus on three today. And those three would be purchasing, effective coverage, and monitoring and evaluation. So purchasing, or what is often called provider payment, is a fundamental challenge in many health systems in this region. In part because most health system managers are now trying to change the way they purchase services, and this is where you get significant potential efficiency gains and effectiveness gains in your system. What many people are trying to do is move from a system that originally had, in many cases, had used fee-for-service to some combination of capitated primary care and case-based payment for secondary hospital care. This is technically very, very challenging, and it requires good data, it requires skilled people, and it requires time. Secondly is effective coverage, and I'd emphasize the word effective here. Coverage is fine, but simply having a health facility available or a building and somebody formally on staff is certainly not effective coverage. And there's been more and more work in this region, especially in Indonesia, Laos, and Cambodia, on the nature of what effective coverage is. And that means that staff are not only on payroll but are there, that equipment not only exists in theory but in reality, and that staff not only have been formally trained but actually demonstrate the ability to do proper diagnoses. Effective coverage is, especially for primary care, which is where you kind of get your biggest kind of gains, is a challenge in this region. Let's put it that way. And finally, M&E, because when we say the word universal coverage, we're really, again, talking about a set of interlinked reforms. So to say we're monitoring UHC is a bit of a misnomer. What we're trying to do is monitor a whole range of things that are going on simultaneously. And if you're a policymaker, this can be very confusing. If I'm making progress on number 1 and number 2 and falling behind on 3, 4, and 5, am I achieving UHC or not? And this becomes the challenge of M&E. And also, frankly, just not having adequate data to figure out if an intended reform is having the effect that you hope it will. So M&E becomes central to the whole UHC process. Right now, JLN supports 5 technical areas of work. One is sort of the backbone we call, which is information technology and data. How do you leverage that to sort of design your system in the most effective and efficient way? Improved methods for purchasing health services. This is usually government or insurance firms, usually government payers. Better means for reaching a hard to enroll or reach populations. These are often poor or marginalized people or informal workers. How to improve the quality of services. I almost call this the kind of the missing dimension of UHC, the thing that's invisible but so important. And finally, how we can more systemically improve both the quality and access to primary health care. Because without a good primary health care system, UHC becomes impossible to achieve.